Dr. Deb.
Okay. My talk is on about when we should order dialysis, and we'd look specially at the timing of dialysis in acute kidney injury. So I'd restrict myself to acute kidney injury. I'd not be talking about chronic kidney disease. What we do is we just look at the basic concepts of acute kidney injury, then we'd look at the timing of dialysis, then we'd follow an evidence-based approach, what the evidence says about timing of dialysis. We'd decide the modality of dialysis, and finally we'll conclude. Okay, this is our beautiful kidney. This is the corpuscle of the kidney. There are 10 lakh of such corpuscles in each kidney, so we have 20 lakh of them. The important feature of the kidney is that it has an afferent artery as well as an efferent artery. So we have control at both levels. We have control to how much fluid goes in as well as how much comes out. We are able to manipulate the blood pressures, the pressure inside the glomerulus by these two devices. So we have a huge capability of auto-regulation. The blood pressure, mean arterial pressure might just be down to 65, 70. Still, we find that the kidney has proper blood supply. Glomerular filtration rate stays the same. And it stays the same till a very high blood pressure of 200. Once we go below 70 mark, then all of a sudden the auto-regulation fails. So it's rather late. Other important thing that I want to show you is the circulation of the kidney is such that the cortex is very richly supplied, whereas the medulla is not very well supplied. The reason is because the medulla should not be well supplied so that we are able to maintain a osmotic gradient in the kidney. We find that the PO2 in the cortex is quite high, and as we go lower down into the medulla, the PO2 keeps dropping. Now what happens is the medulla does not have any functional tissue, much of functional tissue. So the oxygen requirement is also very low. The parts which are usually involved in acute kidney injury are the watershed zone in the outer medulla, the S3 segment and the medullary thick ascending limb of Henle. These are the two segments involved. And the good part is that once you get injured, this can heal itself. Whereas if a glomerulus is damaged, it would not heal. The stock of glomeruli we are born with, and we have to stay with that same stock. A glomeruli lost can never be rebuilt by the kidneys. So the causes of acute kidney injury, as we very well know, can be classified into pre-renal, that is hypovolemia, cardiac failure, hepatorenal syndrome. Then the renal cause. In the renal, again, there are three aspects. One is the tubulointerstitial system, so we can have tubulointerstitial involvement, the tubules, that is acute tubular necrosis, and glomerulus. In addition to that, vascular involvement also might be there. So the important thing to note is most of acute kidney injury is acute tubular necrosis. This constitutes around 50% of acute kidney injury in hospital settings, but we have a significant part of acute and chronic kidney disease as well as pre-renal obstruction as well as acute nephritic syndrome. Now, how do we assess the kidney functions? We have just very limited resources to assess the kidney functions. The two commonly used are urea creatinine that we have been using for a very long period of time. However, urea and creatinine take some time to rise. For example, if someone undergoes bilateral nephrectomy, it would take quite a bit of time for the creatinine levels to start rising. So, a more important one would be using urine output, because the output might drop, though we might have non-oliguric renal failures as well, in which the output never drops. So that is the fallacy of using urine output. We have got newer markers coming up like cystatin C, which is almost like creatinine. We have got NGAL and KIM1. We'll talk about this in a short duration of time. And then finally, in those in whom we find the glomerular involvement is there, urine routine examination and renal biopsy is helpful. Now, this is the classification system of acute kidney injury, and this is based on just two criteria. One is the serum creatinine values, the second is urine output. So, a drop in urine output of less than 0.5 ml per kg per hour, that is for a 50 kg man having less than 25 ml of urine, for more than 6 hours constitutes CKD stage 1. Acute kidney injury stage 1. Stage 2 is when this same thing occurs for more than 12 hours. Or we have just a 0.3 rise in creatinine, or rise between 1.5 times to 2 times. Between 2 and 3 times would be acute kidney injury stage 2. And finally, Stage 3 would be more than 3 times rise in creatinine or requirement of dialysis. This is the akin staging that is being used recently and has been approved by the guidelines of KDIGO as well. Prior to this, we had multiple definitions of acute kidney injury, and this makes comparing older studies very difficult because we are not able to compare apples with apples. The rifle criteria was used previously. This is almost the same till the first 3 stages, but it adds loss in which someone requires dialysis for more than 4 weeks, and finally end stage, that is more than 3 months. The other important factor to understand is acute kidney injury is not only the effect, but it is also the cause of multi-organ dysfunction. So once you have the kidney failing, it will affect the brain, it will affect the lungs, it will affect the bone marrow, it will affect the heart as well as the liver. So it works both ways. These diseases can lead to kidney injury, and kidney injury can further perpetuate multi-organ dysfunction that occurs. In managing acute kidney injury, most of the interventions are those in whom it is high risk, and this is where we can really intervene. So we have to discontinue nephrotoxic drugs, we have to ensure that there is volume status, functional hemodynamic monitoring is to be done, serum creatinine and urine output are to be monitored, hyperglycemia to be avoided. From acute kidney injury stage 1, stage 2 and stage 3, we just find a few things being added. One is we go ahead with more workups in stage 1. In stage 2, we have to check drug dosing as well as we have to consider renal replacement therapy at this particular stage. So those who have urine output less than 0.5 ml per hour per kg per hour for more than 12 hours, we should start considering renal replacement therapy, consider a ICU admission, and finally in stage 3 we can maybe require dialysis. So who are the high risk patients? Older age group, diabetics, hypertensives, those with pre-existing chronic kidney disease, those with heart failure, vasopressor use, high risk or long surgery, emergency surgery, IABP requirement, and long-term on cardiopulmonary bypass. So the indications of urgent renal replacement therapy, these have no doubts. So this is like refractory volume overload if any patient has, someone has severe hyperkalemia more than 6.5 or rising potassium levels, signs of uremia like encephalopathy or pericarditis occurring, severe metabolic acidosis occurring, certain alcohol as well as drug intoxications. These have no doubts. We have to dialyze these particular patients. However, there is a big group of people who advise early initiation of dialysis. This is initiation prior to development of these classical symptoms. So if we initiate dialysis prior to any of these symptoms, this is called early initiation of dialysis in acute kidney injury. And the advantages told was fluid and metabolic hemostasis would be better, inflammatory mediators would be removed better. However, this has disadvantages as well. So we have got catheter-related bloodstream infections, hemodynamic insults, bleeding, as well as risk of increased costs. So we have got a number of meta-analysis in this. So I'll just take up one meta-analysis. This is the analysis done in 2016, which compared all the studies prior to 2016, and it compared acute like dialysis early initiation versus initiation only after symptoms developed of that we talked about. And they found that there was absolutely no difference in all these studies in terms of mortality. This is the most important factor. Secondly, length of hospital stay was slightly less in those who were dialyzed. However, this too was not significant. However, recovery of renal functions was poorer in those in whom early dialysis was done. This is based on meta-analysis. But the best form of evidence that we have is usually considered to be prospective randomized trials. And over the last 2 years, we have had 3 trials which have come. And we just look at this trial. One was the ELAINE group, which was a study done in Germany, and they did dialysis in critically ill patients with just stage 2 AKI before stage 3 itself. And the second group, like in them, the control group was done prior to, like in stage 2, and the other group was with stage 3 AKI. They, however, used NGAL as a marker, and NGAL should have been more than 150 nanogram per milliliter for them to be enrolled into this study. And what they found was there was a marked difference between those in whom early dialysis was done versus those in whom late dialysis was done. The difference was up to the tune of around 20% difference. In those in whom early dialysis was done, they had lower mortality. The patients were again elderly, but they had very high mortality, 65% mortality in the delayed group, very high, 44% in the early group, but still high. and they found that these patients in whom early dialysis was done, however, they survived better. Along with this, two other studies came up. One was the Acute group study, which was from France, and this study again, they compared, it was a multi-center randomized controlled trial. They included only patients with KDIGO stage 3 with mechanical ventilation and requirement for catecholamine infusions. They did not have any potentially life-threatening complications of renal failure that we talked about, and they were again subjected to early strategy in which they were put to dialysis immediately versus the delayed strategy in which only those who developed the particular indications were dialyzed. So what they found was, again, we have got rather elderly age group, 64 years and 67 years of age, the patients being with a large number of comorbidities, usually having chronic renal failure, hypertension, diabetes, congestive heart failure. And however, they found that there was absolutely no difference again between the early strategy versus the delayed strategy. So there was no difference in terms of survival. However, 50% of those who were put on delayed strategy never required dialysis. So this strategy again tells us that maybe it's not such a good idea to go ahead and dialyze such very early. Again, in terms of long-term urine output as well as in other features, there was no particular difference. So we have got these studies, START, AKI, ELAINE, AKIKI. Among these studies, only the ELAINE study showed a benefit. However, the benefit might not be due to early initiation of dialysis, but might be due to the better selection of patients, because what they used was NGAL. This is a novel marker which has come up, and this marker usually helps us in differentiating between those with acute tubular necrosis versus those who do not have acute tubular necrosis. A cutoff of around 150 is used for this, and more than 150, usually they have more AKI, and it goes on progressing with increasing severity of renal disease. So we have levels of around 800 in those with failure. In injury, they have around 300 levels, and this correlates with acute kidney injury. So maybe it is use of this marker in this particular study which helped in the difference in terms of prognosis. However, we do not have this study yet standardized for the Indian population, or we do not have it available in our country. The next question would be, what is the modality of RRT to be selected? So do we select the more expensive continuous renal replacement therapy which goes on throughout with very slow blood rates, or we select intermittent hemodialysis, which is rather cheap to do, acute peritoneal dialysis, which was done very frequently previously, not being done very much these days. So the benefits proposed for CRRT was that there is more of hemodynamic stability. There is better clearance of inflammatory mediators, better salt and solute clearance, and better preservation of cerebral perfusion. However, this did not transmit into real patient benefits. So, the meta-analysis showed no benefit absolutely. There were two prospective randomized trials, and these trials again did not show any benefit in CRRT versus in intermittent hemodialysis. In fact, in the CRRT group, there was delayed recovery of patients, as well as there was increased in hospital mortality, though it might have been just because the patient groups were not very comparable, though they tried their best. Again, there was another randomized controlled trial which again goes on to show the same thing, that you take elderly patients, you do not have any particular benefit of doing a continuous CRRT versus intermittent hemodialysis. We see also this study showed us the adverse events that occurs during renal replacement therapy, which are hypotension, bleeding events occurring, thrombocytopenia, developing hypoglycemia, hypophosphatemia, hypothermia, as well as arrhythmias, in addition to catheter infection, of course, which is there. Then we come to the question of doing acute PD. Acute PD has just been compared in two studies. Not very many studies are there. It is not practiced routinely in the United States. However, one of the studies was done in Vietnam. This study showed a marked difference, with the prognosis being very bad in those in whom acute PD was done. The mortality was much higher, 15% versus 47% in them. However, they did not use high volume peritoneal dialysis. With high volume peritoneal dialysis, again, we find that there is no much difference with intermittent daily hemodialysis versus high volume peritoneal dialysis. So, no difference in mortality or recovery of renal functions in using any of these modalities. So finally, we have a question like, let's say there is a 66-year-old lady who has undergone CABG with mitral valve replacement. She is hypotensive, requiring epinephrine, and she has developed acute kidney injury, oliguric. She is already being given furosemide to maintain her urine output, but still it's not maintaining. She is going into volume overload, and she has blood urea nitrogen of 38 and a creatinine of 1.6. What do you think would be the best renal replacement strategy? Whether we start dialysis immediately, we wait for 8 to 12 hours of oliguria to be set in, we wait for particular blood urea nitrogen values like between 40 to 60 or 75, or we wait for objective evidence, volume overload, hyperkalemia or metabolic acidosis, or there is insufficient evidence to support any of the single treatment strategy? The answer is the last. There is still insufficient evidence to suggest that there is any particular strategy to be used. So it is basically individualization that has to be done. So why is that so? It is because the elephant is fallen. It's a big insult that results in acute kidney injury. So it does not matter who tries to push the elephant. It does not matter. The elephant will have to get up on its own. Otherwise, it won't really matter. To summarize, finally, we have acute kidney injury through stages 1 to 3, in which we have to think of dialysis, think of renal replacement therapy in stage 2 of acute kidney injury. So when the creatinine values are around 2 or so, we should start thinking of it. Though we should not go ahead and do it, we should do it only when it is required. The other factor is maybe the window of opportunity in which acute kidney injury occurs. There is a gap of 8 to 48 hours in which newer markers might come, which might help us in initiating dialysis early. And finally, we have to understand that this is not just a simple process, the process leading to complications. It is a two-way track. The complications lead to further insults, which lead to further complications. So it's a very bad case scenario. So however, what we need to understand finally is acute kidney injury requiring renal replacement therapy has very bad prognosis. Mortality more than 50% in almost all the studies. We should plan early but start only when indicated. Finally, the modality of RRT does not have much impact on survival, so it should always be prevention and early intervention to prevent severe acute kidney injury. That will help us in changing our outcomes. That's all. Thank you.
Thank you, Dr. Deb. So we are not taking any questions and we are going to straightway proceed for our next lecture. Next lecture is by Dr. Sonia Arora Gupta. She is going